2, 1. Please start, sir. We are live.
Okay. Uh, Good evening, doctors, and welcome to this Bare Eyesight meeting. We are delighted to have you join us for this focused clinical exchange. Tonight session brings together leading retina expert to explore real-world strategies, treatment durability, and evolving approaches to fluid management. At Bayer, we are proud to support platforms that foster peer learning and evidence-based care. Thank you for being part of this dialogue. Let's begin with the introduction of today's speaker. Our first speaker today is Dr. Shobhit Verma, sir, and we are delighted to welcome you, sir. Shobhit, sir, is a consultant vitreoretina specialist at ASG Eye Hospital, Patna. Sir is with advanced training at LV Prasad Eye Institute and Shankar Netralaya. Sir brings expertise in retinal surgeries, ROP, and uvea care. An award-winning researcher and published author in leading journals, Sir is recognized for his contributions to both clinical practice and academic ophthalmology. Today, Shobhit sir will be speaking on translating research into practice, real-world applications of DME management strategies. And our second speaker today is Dr. Souvik Dan, sir. So it's my pleasure to introduce you, sir. Sir is a consultant in cataract and vitreoretina services at Disa Eye Hospital. Sir is a graduate of Bardhaman Medical College. Uh, Sir has completed his MS Ophthalmology at the RIO Kolkata and holds FICO Part 1 and Part 2 certifications with fellowship training in retina. Sir has been servicing Disha since 2015, bringing expertise in complex retinal care and cataract management. His innovative work has earned recognition, including awards at national conferences. Today, Sir will be speaking on visual outcomes in DME, assessing the efficacy of Q16 aflibercept injections. So now I welcome Shobhit Sir to start his presentation. Welcome, Sir.
Thank you. Are the slides visible?
Yes, sir.
Yes, sir.
So, translating research into practice, real-world applications of DME management strategies. The current landscape of the anti-VEGF in the DME treatment involves a multiple anti-VEGF. So we have multiple studies who have analyzed the efficacy and the safety profile with landmark trials in ranibizumab, faricimab, brolucizumab, and aflibercept. So there are multiple studies, the RISE and RIDE pooled studies, which was done primarily for the ranibizumab group. Then it showed that the anti-VEGF effect of ranibizumab is much superior to that of the laser effect and the sham treatment. Then the Yosemite study, which analyzed the treatment analysis between aflibercept and the faricimab group. Then there was a KITE study which showed compared the brolucizumab with the aflibercept group. The efficacy of aflibercept treatment in DME is supported by evidence from robust clinical trials, as we can see through the VIVID and the VISTA trial, where it was seen that the patients who were given treatment beyond more than 3 years, and that subsequently led to very reduced number of injections. Similar data was seen in the DRCR-NET protocol T study. So there is a need for RWE to complement data from the randomized controlled trial and support treatment decision in the real world practice. So it measures the real world effectiveness in the clinic. Patient population is unselected, diverse, and not pre-screened, often presenting with a range of comorbidities. Treatment is based on physicians' decisions, typically includes very diverse outcome measures. The real world evidence provides essential information on patient impact, worldwide differences depending on the countries and demography, and the value of treatment, especially considering our country where it's a developing nation and a lot of the patients who belong to poor socioeconomic strata. The endurance study, which shows the patients from VISTA maintain visual acuity gain for 5 years with a mean of 3.4 injections in year 5. Patient in these kinds of in this study, it was observed that the patients were at 4, 8, and 12 weeks intervals, depending on the disease stability. There was substantial reduction of treatment burden through 2 years. 25% of the patients required no retreatment, and 48% of the patients received 5 or fewer injections subsequently. Now, similarly, it was the aflibercept benefit was seen in the RCTs conducted by in the Apollon study and the Moorfields trial. Now, comparing the aflibercept with dexamethasone implant for the recalcitrant diabetic macular edema, especially in pseudophakic eyes for 1 year outcome from a randomized study in India, it was shown that the aflibercept and dexamethasone implants for DME, the outcomes were very comparative. However, it required there was a lot of cases in which the pressure was rise of IOP was seen, leading to glaucoma at subsequently at 6 to 9 months, and so those patients required IOP lowering agents, and this was more of a problem in phakic patients where the complication of development of cataract was more. The intravitreal aflibercept showed a very similar visual and a very good central macular thickness improvement in recalcitrant cases, and there was seen that it led to the improvement of more than 3 lines visual gain, but there was more required number of injections and follow-ups with aflibercept as compared to dexamethasone. Now, similarly, in the DME guideline of India, which was published in the AIOS, in the All India Journal, the intravitreal injections of anti-VEGF agents are the first line of treatment for treatment-naive center involving DME. Multiple clinical trials have demonstrated that anti-VEGF therapy is more effective in improving vision in central involving DME than the macular laser treatment, supplanting as the first line of therapy for center involving DME. The most common reason for the non-response to anti-VEGF therapy was due to inadequate treatment as per the above protocol. In eyes with persistent DME and visual acuity less than 6/12, a different anti-VEGF may be considered. If the patient has been on bevacizumab, a switch to ranibizumab or aflibercept is recommended. And if on ranibizumab, a switch to aflibercept is advised. The international recommendation and guidelines recommend that the use of aflibercept in patient with BCVA less than 20/40. Now, patient presenting with a BCVA of less than, in those cases, it's one of the drug of choice for DME in such cases, and it shows that the superiority to bevacizumab over 2 years and over ranibizumab in the first year of treatment. In patient with very poor visual best corrected visual acuity, aflibercept may lead to a more rapid visual acuity improvement than ranibizumab. Then superiority of aflibercept was noted in the group of participants with worse baseline visual acuity. There is evidence of possible differences in drug efficiency in patients with DME to the disadvantage of bevacizumab at a visual acuity which is less than 20/50. Now, this Cochrane meta-analysis, which is considered gold standard, reviewed evidence showed a major study investigation efficacy of anti-VEGF agents in DME. At year 1, all efficacy outcomes significantly favored aflibercept over ranibizumab and bevacizumab. Patients were approximately 30% more likely to gain more than 3 lines with aflibercept than with ranibizumab or bevacizumab at year 1. For every 1,000 people treated with aflibercept, 92 fewer would gain 3 or more lines of visual acuity at year 1. Now, the meta-analysis also showed that aflibercept is the most favorable treatment for patients with DME. Now, coming to the intraretinal fluid parameters on which we give anti-VEGF injections, the morphology of the intraretinal cyst and RP structure makes a very important part in decision making. Because the kind of anti-VEGF we give, we have to assess what the counseling on the basis of how much the patient is expected to respond to the treatment. Now, such cases where there are in diabetic cases, it's very difficult after a very prolonged stage of disease. It's very difficult to attain a very dry retina kind of a picture. So, intraretinal fluid, especially the exudative intraretinal fluid, needs modulated intervention. The degenerative intraretinal fluid, which are shown by the sharply demarcated hyporeflective spaces in the inner retina overlying areas of RP atrophy or scarring, they can be considered for treatment discontinuation when the disease is stable. Now, discussing few cases, this is one of a case where this patient was having chronic diabetic macular edema with history of multiple anti-VEGF. He has been given Ozurdex, ranibizumab, aflibercept, but the thing is, no he was not being explained that he needs a continuation of the treatment of the same molecule. So this patient, when he came to me, was having large cavitational spaces as well as IRFs, that cystoid spaces. There was some RP alteration of outer retina also. So I explained the patient that he should undergo aflibercept injection for the 6 weekly interval for 3 doses, and after 3 doses, he had a very good resolution. Although the visual acuity was it improved from the time he presented to me, but still he was able to achieve the best corrected visual acuity of 6/36 only. But this showed that this medication helps if given in a proper dosage, and a regular interval has to be followed subsequently. So one of the other cases where this patient was 50-year-old, he presented with a chronic DME. 4 doses of monthly ranibizumab biosimilar was given. However, the intraretinal fluid, the cystoid spaces, when altered foveal contour was persisting, there were some hard exudates correspondingly. So again, I asked for starting with the aflibercept injection, and we can see so beautifully that the intraretinal fluid spaces had resolved, the vision was improved, the hard exudates can be seen, but the foveal contour was intact, so he was maintaining a good vision. So I kept this patient on a treat and extend regimen, so I had to continue the treatment. Now, another case where recurrent CME was seen 10 weeks subsequently. So this, I was keeping him on treat and extend regimen of aflibercept injection only. So what the rule which I follow is that I try to extend the gap till maximum of 16 weeks if possible. If there is recurrence, I try to modulate it to the previous interval when the disease was stable. But what I have noticed is that if the patient is properly counseled and the interval is properly maintained, and the patient is seeing the benefit of the anti-VEGF and not just randomly to haphazardly advise that we need monthly doses for the every 6 or 8 months, then it's very easy. Like, it's much easier to counsel him for a higher cost injection such as aflibercept, which has a very great result in such diabetic macular edema cases. Thank you.
Thank you, Shobhit sir, for a wonderful presentation. And you started with the study, then conclude with the case-based presentation. It is really helpful for our audience to give them the confidence. And what you are saying, that in which case you shift from Rani to Appli, and how much you can extend up with the treat and extend study, that you can extend up to 16 weeks. So it is also the many patient there is a complaint that how long are you to take this injection and how frequently. So we can easily address this point with this kind of Q16 point, that you can there is a less burden of the treatment for this kind of group of patient. So now is open for the audience. If there is any question from the audience, and I also requesting Shobhik sir, please throw some light on this point, because you are also practicing in the Disha. You have seen many patients, so you share your experience on this kind of patients. Thank you.
So thank you so much for your introduction. Am I audible?
Yes, sir. Yes, sir. You're audible clearly.
Very nice presentation, Dr. Shobhit.
Thank you.
So my question to you, do you prefer loading dose to all of your DME patient?
Yeah, when the patient is presenting to me first, then I ask for the loading dose, for the monthly dose for the first 3 months. Depending on the injection, if the patient is counseled for aflibercept injection, generally if the patient is having good vision, like beyond 6/12, and there are not much hard exudates, then I generally don't start with aflibercept. I initially ask for ranibizumab biosimilar or something, ranibizumab injection, and initial 3 monthly doses I give. After that, I make the interval gap of 8 weeks. Then I shift it to the 8 weeks in phakic patients. This is my priority for the phakic patients. And subsequently, if the patient again develops macular edema, or if the patient is not responding to the first or second dose of ranibizumab, like if there is neurosensory detachment which is persisting, even if the intraretinal fluid is resolving, but that neurosensory detachment part is there, then after first or second dose only, I try to counsel the patient to shift to aflibercept if the patient is phakic. If the patient is non-affording, or if it's pseudo-phakic, then there is a second priority which I keep, also dexamethasone in my mind. because if I directly jump from ranibizumab, so now the aflibercept injection cost, Eylea injection cost has reduced significantly. That previously it was not very easy to give a 20,000 injection and directly asking the patient to now you shift to 65,000 rupees injection. So now the things have changed quite a bit when the prices have been revised. But generally, this is the if the patient is affording, then obviously I ask for aflibercept loading dose, and then subsequently I increase the gap.
So, do you counsel all of your patient from the first day that aflibercept is
No,
as
no,
an
no,
option? No.
no, no. I don't
You
counsel
start
that.
with ranibizumab
So if the
biosimilar.
patient is presenting first, then I give only that option of like now. See, initially I start with that ranibizumab or ranibizumab biosimilar. That is the first thing. Now, because that aflibercept price is almost reached to the level of Accentrix, if you can say.
Mhm.
So if the patient is affording, then we can give. But the thing is, priority and in start, I start with ranibizumab only. I don't give aflibercept as a first choice.
And you actually consider switch after 2 weeks to two injection of ranibizumab. Then
If
you
it's not responding, if it's not responding.
not responding.
Like
You
if I'm seeing that even after the third dose, after 1 month again the patient will come that it has not improved.
Hmm.
Then to again say that now you go for the fourth dose or on the fourth injection you have to switch. So that time in those cases, mostly I consider those that subretinal fluid component, that neurosensory detachment part. If that is not going, then I found it very notorious. Like most likely with the third dose, little bit more it will compact, but eventually after 6 weeks it will again come up.
Yeah.
So that is my priority. If that subretinal fluid as component is gone, intraretinal fluid spaces are there, then that case I go with the third dose of ranibizumab.
And what about your strategy to tackle the hard exudate?
Hard exudates with macular edema, generally that is I prefer dexamethasone. If
First.
there is fluid component, if there is no fluid, I don't give. If it's compact retina, only hard exudates is there, then I don't give. Like just at the or hard exudate plaque. Then in those cases, I have not seen any benefit. Like whatever is my experience, I have not seen much benefit. But in those cases where there is a lot of hard exudates, those so in those patients, if the patient is pseudophakic, then directly Ozurdex. I don't consider anything else. If phakic and the patient is affording, then in that case I consider aflibercept if the patient is able to pay. But because of the cost factor till now, like till my practice till March, so that factor was there, especially in Bihar. It's a quite a big thing. Like I cannot just if I ask the patient to go for three aflibercept and some other doctor outside says Ozurdex, then obviously we'll find and it will work also. So it generally so I have to that socioeconomic factor also have to be kept in mind for planning such cases.
And do you consider the anti-VEGF with dexamethasone or triamcinolone in the same sitting?
Try see I have actually I have never practiced like I have seen people giving, but during my fellowship and even in LVPI, so this they have never I never saw anyone doing that. So intravitreal tricot, though I only give intraoperative only, like sometimes if needed, but generally in vitrectomized eye I give. In non-vitrectomized eye,
You don't give.
I avoid.
Okay, okay, okay. Thank you so much.
Welcome.
Thank you, Shobik sir. Thank you, Shobik sir. So our next presenter is Dr. Shobik Dunn. Sir, now since we send and over.
Okay, I'm sharing my screen.
Yeah, it's coming.
So is it visible?
Yes, sir. It is visible, sir. Clearly. Sir, just switch on your camera, sir.
Okay.
Yeah, it's okay, sir.
So hello everyone. Today my topic is maximizing the visual outcome, evaluating the Q16 injection interval in the DME patient. So these slides are permitted only for the purposes of the scientific and educational content only. Diabetes is increasing globally at alarming rate. In 2019, there was 463 million of patient, and by 2045, this is expected to reach 700 million. As diabetes increases, the sight-threatening diabetic retinopathy and DME will also increase. This means a larger treatment burden for both patient and the clinic. So DME is a major cause of the vision loss uh, in working age adult groups. Around 28 million people worldwide already have the DME. So vision loss is actually the most feared complication of the diabetes, even more than loss of a limb or memory. So why the vision gain matters? So every small improvement in vision make a big difference. Gaining one line may help patient to read a newspaper or drive better. Gaining two line improves the daily activities like cooking or walking. Gaining three lines can improve color perception, so on. So every letter gain matters. So coming to the need for individualized treatment. Earlier, the fixed monthly dosing was common, but now we understand that the patient respond differently. Therefore, the treatment has evolved towards more personalized approach such as treat and extend regime. Now coming to Protocol T 1 year outcome. In Protocol T, aflibercept showed the greater vision improvement at 1 year, especially in patients with a poor baseline vision less than 69 ETDRS later. In this patient, aflibercept has had a clinically meaningful advantage over the other anti-VEGF agents. In Protocol T, year 2 outcomes. At 2 years, the aflibercept remained the superior to the bevacizumab. The difference with the ranibizumab reduced over the time, but in patient with the worse starting vision, the aflibercept maintain a better overall visual gains. So coming to the area under the curve analysis, when you're looking at the area under the curve over the 2 years, aflibercept actually provide the consistent higher visual gain in the patient with the baseline vision below 69 letters. So this suggests not just a peak benefit, but a sustained benefit. Now coming to the international guidelines, because of this evidence, many international guidelines recommend aflibercept as a first-line treatment in the DME patient with a best corrected visual acuity below 69 letters. In real-world practice, nearly two-thirds of the patient present with a vision in this range. DRCR.net Retina Network protocols. Aflibercept has been studied extensively, and in the all DRCR protocols such as Protocol T, Protocol V, Protocol W, and Protocol AC, and all these shows a strong clinical confidence in this molecule. So coming to the study, there is a Violet study, long-term maintenance. This study evaluated the patient after intensive 1 year treatment. It showed that the vision gain achieved initially were maintained for a long term, even with the extended dosing interval. So importantly, the treatment burden was reduced. Coming to the VBIM study, and it is a treat and extend protocol. It's a proactive treat and extend protocol. And at the 2 years, around 35% patient gained the 15 letters or more. The mean vision gain was maintained and injection frequency reduced at the year 2. So this support the extension after the initial control. Coming to the Hirano study, up to the 16 week. In this study, the interval was extended up to 16 week. Majority of the patient achieve a 16-week interval, and the vision gain maintained over the 2 year with the reduced injection burden. Now coming to the JET study. In JET study, after 5 loading dose, the interval extension was done. The mean gain was 8.3 liters. 89% of the patient reached the Q12 interval, and many patients achieved the disease stability early. So can the patient reach to greater than Q12 or Q16? So across the multiple prospective studies, many patients were able to reach the 12 weeks or longer interval after proactive 1 year treatment. This supports the concept that the extended dosing is achievable in the selected patient. Coming to the safety profile, the aflibercept has over 10 years of the real world experience, over 56 million of the doses, more than 8 million patient years of exposure, very low rate of intraocular inflammation, endophthalmitis or vasculitis, and this provides reassurance regarding the long-term safety. So coming to the summary, diabetes and DME burden are rising, so early intensive treatment gives a maximum visual gain, and aflibercept show a strong benefit, especially in the poor baseline vision. And treat and extend treatment regime actually allow the reduction in the treatment burden. And this many patient, not all patient can achieve the Q12 to Q16 week interval. And early treatment plus good systemic control has maintained the long-term visual gain. So thank you so much.
Thank you, Shovik sir, for an insightful presentation. How you discuss the every study, like it's backed up by the ILIA. It shows the confidence of the globally how what we claim that is backed by our scientific documents. So obviously, it will give the confidence to our audience to using for the treat and extend as a regime ILIA. So now the forum is open for the audience. If there is any question, otherwise I will request Dr. Shobit Verma sir, if any point from your side, or you want to highlight any point.
So, just I wanted to ask Dr. Shovik, like, how do you decide between aflibercept and Ozurdex? Like, what is your preference?
Oh, this is a very good question. I generally didn't prefer Ozurdex at the very first visit, be it a phakic or pseudophakic patient. I generally prefer anti-VEGF. But the DME is actually multifactorial. There are lots of it is not a VEGF oriented disease. It is some multiple times it is actually there are interleukin and MCP. So you actually have to consider the Ozurdex part, or I actually give a um, triamcinolone acetate also, where patient can't actually afford the treatment.
Mhm.
So generally, I start with the anti-VEGF, preferably aflibercept or faricimab. If patient can't afford, then switch to ranibizumab biosimilars, etc. And after giving 3 loading dose, I actually uh, take a pause, and if switch, then I actually explain the patient this therapies might be not working for you. So I actually switching this, and this is maybe your prognosis.
Mhm. And what about the renal parameters? Like, how do you decide about it? Like CKD patients and all.
In CKD patient. In CKD patient, you have to use the Ozurdex kind, and this type of patient I actually give a Ozurdex, and I generally I do laser quite a small
Grid, grid,
in the
focal grid
CKD,
laser.
focal laser or PRP.
Mhm.
In CKD patient, I prefer laser.
Okay.
So thank you, Shovik sir. Thank you, Shovik sir. We are just planning. We planned this meeting because, as we all know, that the AAC is now it's a growing ophthalmologic institute across pan India, and in East or in West Bengal, we cannot think the ophthalmology without Disha. So our main motto was to conduct in this meeting so that we from ASG, from Disha, they can interchange their view. And so with this view is also helpful for our audience because they can know what is now the protocol treatment and what the protocol they are like following from Disha and ASG. So many doctors now who are like now practicing retina, they're giving like injection. It will be helpful for them. So hopefully in future we will again conducting this kind of meeting, exchanging the view of the institute, and that also helpful for the audience. So thanks once again, Shovik sir and Shobit Verma sir, for your valuable time.
Thank
Thanks.
you. Thank you. Good night. Good night.
So now I'm requesting our technical team, please log off this meeting link.
We are offline, sir.
Thank you. Thank you. Good night.